analyze the different research works. The focus of the office is in the digital 3D, in the virtual reality, and also we organize a lot of intensive courses and training for people around the world. This is a group from Mexico, people from Brazil, Portugal, Poland, Ukraine, Beirut, Japan, Colombia. Different groups come to the office. And normally we have learning orthodontic around the world. We have groups like this. This is the group of Thailand. And after the first course in Thailand, we have a second course, Typodont in Thailand. And after, the people from Thailand come to Spain and come to my office. What is the problem with the coronavirus? Okay, we have a very huge problem with the coronavirus, and maybe what is the future of our profession? Is possible to use only aligners in the future, or is possible to combine aligners with brackets and wires? This is a very interesting question. Remember this, most of the techniques that we are using today, Roth, Andrews, Tweed, Tip-Edge, was created many, many years ago, in the time of the Rolling Stone. This is the car we used it many, many, many years ago in Spain, and nowadays change a lot the car. We have now electric cars, and you can see now how are the Rolling Stone, the change of the face and the change of the age. Okay, we have two possibilities. One possibility is to do classic orthodontic, is the classic orthodontic, and the other possibility is to use aligners, Invisalign, or even expensive treatment. We developed the DSQ technique. This is our orthodontic technique, and we mix the aligners with the classical orthodontic. For the reason we have the protocols of diagnosis and protocols of treatment. And we use the straight wire low friction system for the brackets and the metallic wires, orthodontic microimplant system, eruption and proprioception guides and aligners, and the use of digital and functional appliances with another company. The first company is Rocky Mountain Orthodontic from Denver. The second is Thiacom from Spain. And the third and the fourth is OrthoPlus and Alinea Dent from Spain. Nowadays, we are using the gunmetal. Gunmetal is a new alloy and present the big advantages to use only one alloy for all treatment. It's possible to treat a patient with two or three wire is enough. One wire is 16 or 18, and the rest of the treatment is 90 by 25 gunmetal. And with only one alloy, it's possible to do all the treatment. We developed a new system of orthodontic microimplants. And we are talking now today about the third part of our technique. And this part is the aligners in mixed dentition. Okay, we are now launching to the market our microimplants. This is intraoral microimplants and the extraoral microimplants. You can see here the catalog of the brochure of our microimplants. Is a very nice brochure to explain how to put each microimplant in different cases with a box. It's a surgical box with the screwdriver and the different types of microimplants. And in the other hand, we developed the straight wire low friction technique with the synergy bracket and with different wires. Nowadays, we are working with a close friend of mine. This is the owner of the OrthoPlus company. and I am the European Academy, director of the European Academy, Academy. And we wrote different articles. Unfortunately, the articles are in Spain in the Dental Tribune International. Okay, this is about when to start the treatment, what is the treatment, what is the best time to start the treatment, the best age. Okay, I have the YouTube channel with different in Spanish presentation and videos, but I have 2 or 3 presentations in English. Okay, this is the evolution of the orthodontic. Remember, first was angle, second was the technique of twist with the strike wire by Larry Andrews. Dr. Ricketts was one of the most spectacular orthodontics in the last century. Introduced the computer in our clinic, introduced the fixed appliance treatment in mixed dentition. I like very, very much in mixed dentition the philosophy of bioprogressive technique, using the combination between the coachelis and the utility arch. In the 80s, Roth introducing in the history of orthodontic the idea of functional occlusion, the new development of the new brackets, the new systems in orthodontic like MBT. In 2000 was very important the concept of the evidence-based orthodontic, and the introduction of super wires, the digital orthodontic, and in the future will be the development of the development of the different memory shape polymers, the memory polymers to create a more effective appliance using aligners. Okay, and this is excuse me. Okay, and we are talking about the eruption proprioception guides. The idea of the eruption proprioception guides is very simple. In the late mixed dentition, in the moment when we are eruption, the canine and the first molar and the second molar and the second premolar is a crucial moment to adjust the mandible in class 1. For the reason, if you can see here, it's very important that the canine get to a class 1. When the canine get a class 1, the mandible is close to class 1. Unfortunately, when this is the situation. When the upper canine and even the second premolars and the rotation of the first upper molar produce the dental class 2, and the canine in relationship with the inclined planes produce this contact in class 2 between the upper and the lower canine, the big problem is this: the mandible move backward. For this reason, it's very, very important the relationship between the eruption of the premolars, the upper canine, and the second premolar in relationship with the TMG. For this reason, it's very important the control of the eruption of these teeth. For example, in many cases like this, we put coachelis or we put something very simple to produce expansion and to correct the crossbite of the lateral incisor. And you can see how is the result years after of this first phase of treatment without another treatment. For this reason, it's very, very, very important to intercept the malocclusion, to put appliance in this type of patients very early, to do short, very early treatment. Okay, we working in OrthoPlus in a new dimension of the digital orthodontic. In this screen, you can see a patient. We take in this patient an intraoral scanner of the teeth. Second, we combine the intraoral scanner of the teeth with the CBCT, of the patient, and you can see the real situation of the crown, real situation of the root of each tooth. And this is the real bone, alveolar bone and basal bone according with the CBCT. Okay, this is a big advantages of, you can see the vestibular part of the occlusion of the patient. You can see the lingual part of the occlusion of the patient. It's possible to do a setup or even the mock-up. This is another patient. In the other patient, it's possible to analyze, and for example, this upper canine, okay, or this upper canine, we make the aligner. You can see here the attachment. We make the aligner here in this patient, and you can see the real bone in the CBCT, the real roots of each tooth, and the crown of this. For the reason it's possible to do, and it is possible to do a guide for the eruption of this tooth. Okay, this is the old-fashioned computer 3D setup of this patient. This is more or less 6 months ago. Now we have a new design for the aligners. Okay, and you can see how it's working. Okay, closing the space step by step. This is the number of the aligners. Okay, step by step, closing the space and closing the diastema. Another very interesting research in the department of OrthoPlus research department is the biomechanic of the element, the method, and the finite element method. And this is to analyze the center of the resistance and the center of the rotation and the morphology of the root of the molars. The same when we are studying the effect of the orthodontic tooth movement with the aligner. You can see here the aligner, okay, the aligner, and the effect of the aligner in this tooth and the neighbor and the closed tooth. And this is another advantage very of this. We are using aligners, for example, in adult patient, and we analyze the type of aligner. You can see here. This is the aligner for the stabilization of the appliance. This is for retention of the appliance. And this is the aligner to produce a little bit extrusion. And at the same time, this part is to produce protrusion of this lateral incisor. Okay. This is the studies about the attachment, about the rotation of this attachment. And this is about the anterior proprioception guys. The idea is this, is to avoid that the eruption of the canine produce the protrusion of the upper canine and produce the extrusion of the upper canine, get the occlusion in class 1 and put the mandible as close as possible to in a class 1 relationship. Okay, the eruption pattern of the patient produce a occlusal proprioception. The occlusal proprioception change the position of the mandible and the TMG and produce a change in the growth of the mandible of the patient. For this reason, if we change the eruption pattern of the patient with the proprioception guides, it's possible to change the growth of the patient, only put appliance in the last part of the mixed dentition. This is a new research, and the idea is very simple. It's like this. This is a crossbite. Another problem of this patient is the eruption of the upper canine and the lower canine. And we put in this patient different types of anterior the aligners in this moment to resolve or to treat these problems with this. The second phase of the treatment, or the second aligner, is to put the upper canine in class 1, remove this second lower temporary molar, remove this, move the premolar to distal, move the canine a little bit distal to align the incisor and to produce the protrusion of this incisor. Okay. This is my colleagues in my office. In this moment, we are putting we put the composite, okay, here, the attachment in the patient. In this patient, the treatment is in mixed dentition. For this reason, it's very important to put or to increase the number of attachment and the site of the attachment at the level of the molars, and at the same time put attachment in the upper and the lower incisor to get a good retention of the aligner, because the aligner is preparing for the eruption of the second premolars, in the lower second premolars, and in the upper for the eruption of the canine and the second upper canine. Okay, this is a very, very important slide, because this is the first patient. This is a research project, very interesting. And this patient was the first patient that we treated with this method. You can see here the part of the plastic, okay, to put inside the canine. We reproduce the shape of the canine in this part of the liner. In this case is the same, okay? Now this is a part to put the premolar, and you can see here, very nice, how the canine, in this case in the left, and the right canine came to the space from the canine inside of the liner. The same here. Okay, the same here, and the same is for the second premolar. In the second premolar, it's possible even to correct the rotation of the premolar, okay, before to get the premolar, the occlusal line. What is the idea? It's very simple. With a very simple treatment, with a bite block of acrylic or with a liner, we change the occlusal proprioception. The occlusal proprioception is the peripheric comparator of Petrovic. This is the idea about the servo system, about Petrovic. What is the idea? The most important is the occlusal proprioception. Change the mesencephalic nucleus of the trigeminal nerve, and the trigeminal nerve produce afferences to stimulate the TMG and the muscle. Change the muscle of the dynamic of the mandible, and at the same time change the occlusal proprioception. For the reason, it's a very ecological idea about orthodontic. Why? Because we are using the eruption of the patient, and we are using the spontaneous orthodontic tooth movement of the patient and the eruption forces. For the reason, it's possible to change the growth of the patient only with this very simple method. We have to diagnose the plan of treatment. For example, in this patient, Now it's time to eliminate the second upper temporary molar and the lower second temporary molar. We extract the temporary molars and we design in the setup, in the digital setup, we design the distal movement of the first premolar, the lower first premolar distal movement, and we have at the same time to control the rotation of the second upper and the second lower premolar. You can see here the next step is to produce another aligner with it to get down the canine and the first premolar. And this is the idea. It's very, very simple. I don't have, because this is something very, very new, and I don't have a lot of cases, unfortunately, because I have this, in this time with the coronavirus, is a huge problem to see the patients. But you can see only using these very simple aligners, only in the late mixed dentition, only in a short period of the eruption, you can see this. This is the eruption of the canine with this attachment, with this vertical attachment. We move distal this canine. With this attachment, we move this, remove this molar, and now we get the space to reduce the distal movement of the first premolar and to get the molar in class 1. It's very important in this moment to put attachment in the incisor and also to put the attachment in the upper and the lower molars. Okay, one more. Okay, very, very simple. This is only 2-3 months of evolution of a patient. We, in this case, decide, extract this temporary molar to move this premolar backward. Okay, open the space for this canine and align the 4 incisors. Okay, very, very simple treatment. Very simple. Okay, very simple. This is you can see the effect, the superposition. For example, this is a very common patient in Galicia, in my region. A patient with a retrusion, a little bit retrusion of the mandible in class 2, severe overjet, big teeth, big incisors, Bolton discrepancy. What is the best treatment? What is the risk of this patient? I would like to treat this patient as early as possible because there is a high risk of fracture. Okay, for the reason my first treatment doesn't work very well if functional appliance doesn't work very well. Doesn't work very well to put 4 brackets and headgear. Doesn't work very well. Maybe in this patient, maybe the best treatment with functional appliance is a twin block, because with twin block, you have the advantages to put a screw in the upper, another screw in the lower, and to produce a W expansion in the upper and in the lower, and create the space to move backward the upper incisor. Okay, maybe. In my office, the best appliance is this, the C-modeler. The C-modeler is a very simple appliance was invented for a doctor from Spain, Dr. Cervera. It's a very simple. We have like a silicone, like a splint with a silicone with a high pull, okay, or mixed high pull. What is the C-modeler produce a very quickly lingual movement of the upper incisors. This is the first advantage. The second advantage is this. It produces a very good control. We have a problem. We have a very good control of the growth of the maxillary. And what is our idea? This is was very nice. Our idea was introduce this. After the retrusion of the central incisor, we start with the use of the aligner. The use of the aligner is only to get or to produce expansion, to get the lateral incisor forward, to control a little bit the problem of the molars. In the lingual part, we put the conventional lingual arch. And now it's time to remove, for the pulpitis, for a pulpectomy, we prefer to remove the first temporary molar in the left, okay, and prepare the aligner for the first premolar, for the eruption of the first premolar, okay, with the attachment. And you can see, because we don't have more photos, because it's very start the treatment in the summer, and you can see here, okay, now it's time to the eruption of the premolar, and this is the part to receive the premolar, to adapt the premolar to the vacuum of this part of the appliance, okay? And you can see the use now as a retention. The patient is using the aligner. The concept is a little bit different. When you are using aligners in adult patient, you are using the aligner in the same way that the conventional orthodontic. One tooth is with rotation, you put the aligner to try to treat the rotation of this tooth. The lateral incisor is in lingual, you try to move the lateral incisor to forward. Here is a little bit different. The idea is to treat with conventional orthodontic. In many cases, the incisor and the molar, and the aligner, to the objective of the aligner is to get during the eruption, the tooth to the proper position, and to correct in the same moment during the eruption, to put in the correct position the tooth. A class 3 patient with anterior crossbite, okay, with anterior crossbite, with protrusion of the lower incisors, okay, check the patient in centric relationship, and it's a very simple case. But what is the problem of this patient? The problem of this patient is the muscle. The muscle of the upper lip produces the collapse or the frenum of the growth of the maxillary. And the lower incisor, okay, the inclination of the lower incisor increase the crossbite. What is the main objective? The main objective is the proprioception line. What is proprioception line? Is the ideal line for the eruption of the upper incisor. Okay, what is the best appliance? The best appliance when the patient presents a muscular problem. The treatment is a muscular treatment. When the patient presents a dental problem, the best appliance is a dental treatment. Okay, in this case, the main problem of the patient is a functional problem. For this reason, in this case, we put the Frankel appliance with the screw, with the shields in the upper to eliminate the pressure of the upper lip. These wires to produce protrusion of the upper incisor, and this wire to produce the retrusion of the lower incisor. Check the functional appliance, in my opinion, is very important for the expansion of the patient. It's very important how to adjust the shields of the lateral shields of the functional appliance of the Frenkel appliance to the mucosa, okay, and to the oral mucosa to produce the traction of the periosteum. Okay, okay, and okay. You can see the effect of the Frenkel, the spectacular effect of the Frenkel in the upper incisor, in the lower incisor, very important, the intrusion of the lower incisor, the retroposition of the mandible, everything changed in the mouth and the face of this patient. For this reason, I love the functional appliances. I love the functional appliances, and I don't understand the people who talk bad, not very well about the functional appliance. For this reason, very important. Protrusion of the upper incisor, very important. Forward movement of the point. And now it's time of eruption proprioception, guys. We put different types of here. You put different types of attachment here, attachment for the retention of the appliance. And the use of the appliance in this moment is in passive use, only to adjust this posterior open bite, only to align the upper incisor and to get a good relationship. For the reason, now is time to finish the first phase of the treatment. Now the patient is using this aligner, or maybe we make a new aligner maybe in 3 or 4 months, but use the aligner only for retention. Okay. For this reason, what is the idea? Very simple. The incisor proprioception guy try to get the occlusion in class 1 to control the growth of the mandible, to control the muscle, the trigoideo muscle, the masseter muscle, to control the eruption of the teeth, and to control for the mesencephalic nucleus of the trigeminal nerve, and with the idea of Petrovic about the servo system, or the natological or the stomatognatic system, like a system with the maximum control is the occlusal plane, the proprioception of the teeth. Classical patient of our office, classical patient of our office, very simple, very simple. The idea is very simple. The patient presents a crossbite of the lateral incisor and a collapse, a simple collapse of the maxillary, okay? It's possible to treat this patient with Invisalign kits, with aligners. I don't recommend. The idea is very simple. The first phase of the treatment is very simple. Only using something very simple. A quagelis, very simple quagelis. I like very much this treatment. And now, unfortunately, after the coronavirus, because we need after the coronavirus, very simple and cheap treatment. I like very much the cheap treatment. I'm using a quagelis, very cheap, put a lingual arch. Even I use in the lingual arch omegas to move a little bit this tooth to produce a little bit intrusion. You can see the evolution of the case. Very simple, 4 brackets, an utility arch. And now finish the first phase of the treatment. And 1 year later, in this moment is eruption the canine, the upper canine and second premolars. And now it's time to put the aligners. You can see the big attachment in the incisor to get a good stability to, this is the attachment aligner, to get a very good stability. And this is the attachment in the patient. Okay, the attachment in the patient, in the right and in the left. And you can see now the canine is in class 1, premolar in class 1, molar in class 1, and in this part only need to move a little bit the upper canine and to put the upper canine in class 1. Okay, the evolution of the patient. Okay, and now we are finishing. Maybe next 2 or 3 months, I hope, I see the patient and remove all the treatment. For this reason, we use 1 quahellis, 1 lingual arch, a very simple 4 brackets with an utility arch, and using 3, 4, or 5 aligners. Okay, this is the aligners to finish the treatment after in the second phase of the treatment. Another patient, this is the patient with, they present the problem of the caries here in this second temporary molar, class 3, open bite. Okay, for typical treatment, rapid maxillary expansion in early mixed dentition using, in this case, we are using the rapid maxillary expansion with the La Rosa system. I like very much. We bonding the appliance in the upper temporary canines and put bands in the second molars, temporary molars. Okay. After the treatment, how was the evolution of the patient? Perfect. Now we are finishing the treatment, and this is the occlusion of the patient. We get a very good occlusion at the level of the premolars and the canines, and you can see the end of the treatment. Okay, patient very happy. We are using only 1 appliance to rapid maxillary expansion, and after years and years after, at the end of the second phase of the late mixed dentition, we put, I don't remember, maybe 10 aligners or less and finish the treatment. Another kid with crossbite. The main problem of this patient is the TMG, present sounds in the TMG and a little bit clicking in the right TMG. The patient present the crossbite here in the right and a shift to the mandible to the right. The first step is to try to put quahellis, but the patient presented very, very, very narrow maxillary. It was very, very difficult to adjust the quahellis, and in this case, we decide to put a stainless steel alloy 18 round and with 4 loops, 1 loop, another loop, 1 loop, and 1 loop. This is an excellent appliance when you try to produce expansion and at the same time the protrusion of the lateral incisor. Very cheap, very quickly, and it's very comfortable for the patient. And this is the patient, and finish the treatment. Finish the treatment. Very, very, very simple the treatment. We use only maybe 6 months, 9 months of treatment. Okay, and finish the treatment. Now it's time to the end part of the mixed dentition. The end part is eruption the canine. It's time to remove the temporary second molar. Okay. Okay. And now it's very important to adjust the occlusion. Why? Because the patient presents a TMG, a potential TMG problem. For this reason, the best option is a very simple ecological option. My option is this. I put with a CBCT within intraoral scanner, make design of the path, the camino, okay, the road for the canine and for the premolar. Remove this premolar, move a little bit in the study, in the digital screen, okay, with our program. Distalize the first premolar, remove this and put here to the eruption of the canine. In the right and the left side, the same. It's very important to put a lot of attachment. It's very important to put a lot of attachment because we need the stabilization of the alignment. And this is always a problem. You can see the evolution of the case. Very, very, very nice evolution from very nice evolution. And this is it's not yet the situation, it's the situation 3 months ago. And suppose that now the patient is in a class 1 and we need for finishing only to put 2, 3, or 4 new aligners to end the occlusion. I think it's very, very nice, this approach of treatment, because it's very simple, it's very expensive. Why? Because the idea is the first phase of the treatment is in the early mixed dentition, only with brackets, wires, or Quachelis. Second, we are finishing and to put only aligners in the second part of the second of the late mixed dentition. The control of the proprioception, to control the growth, control the central nervous system, control the trigeminal nerve control the muscle control the TMG, and all control the growth of the patient. For example, cases like these, before and after the use of very, very, very simple treatment, very interesting. Remove the rapid maxillary expansion appliance and McNamara rapid maxillary expansion, remove this appliance, and you can see now the canine, the premolars, the same, and the same. We design a liner to get down the canine, get down the premolar, get down the second premolar, and to get down in a class, and very nice class 1. This is the patient, and we prepare the next aligner in this patient, and we have to control the eruption of this canine and the control of the eruption of this canine. Okay, you can see the evolution of the patient. This is a colleague from my office to put this metal button to strengthening the premolar, because in many cases we use elastic change, or use elastic, or use a small button or a small screw to change the alignment. And you can see here the patient, very simple, extract the second molar, temporary molar, okay, and the rotation of this lateral incisor, expansion to create a space for the right and the left canine. And now we put the attachment in the canine to control the rotation during the growth of this teeth. Okay, and now I am going to talk, this is for finishing, and if you have a question, it's possible to, no problem, because I am going now to talk about, we are going to talk about the mandibular class 1. Is the mandibular class 1. What is your idea about this? One moment. What is your idea about the mandibular class 2? One moment. Okay, and okay, what is your idea about it's a question. Do you understand? Okay. Yes?
Yes.
Okay, okay.
Yes,
okay.
We can hear
you. You need questions about the first part of the.
I think, Professor, we will take the questions at the end in the Q&A tab, and also they might raise them.
Okay, perfect.
So no problem.
Okay, no problem.
Thank you.
Okay, and we are talking about the class 2, the class 2. I like very much to talk about the class 2 because for example in class 3 when we are talking about the class 3 is very simple through the treatment because all the techniques MBT, Damon, structural friction, rickets, Roth are in complete agreement. For the reason is very interesting, we are in complete agreement. For example, in our office, the treatment is very simple. Most of the patients using rapid maxillary expansion and facial mask with McNamara system or with a different type of system. Maybe the most effective is in the primary and early mixed dentition. The great forward movement of the maxillary when we are combined with the facial mask and rapid maxillary expansion. Okay, we are using 5 or 600 grams per side, about 12 hours a day, normally almost during 1 year. And according with Peter Nagan, the maxillary effect and the dental and skeletal effect is about 60%. And mandibular, skeletal, and dental effect is about 40%. For this reason, in my office, all the patients with class 3 malocclusion used rapid maxillary expansion and facial mask, even in patients with mandibular problems. Why? Because according with Peter Nagan, the effect of the rapid maxillary expansion and the facial mask in the mandible, in the total treatment of the patient is close to 40%. Remember this case, in the lower, you can see another patient with a very severe class 3 rapid maxillary expansion, facial mask, and what is the objective? The protocol in my office, very simple. Between 8 and 10 years, rapid maxillary expansion and facial mask, about 1 year, 1 year and a half. 1 year is enough. Okay, 3 or 4 years later, I don't like to use retention. I don't like to use appliances between the first and the second phase. 3 or 4 years later, we evaluate the phase and the occlusion. When the phase and the occlusion is okay, we decide to treat the patient with conventional orthodontic. When the phase is not very good, but the occlusion is okay, I recommend to the patient, to the parents, to take a decision about the surgery or not, or camouflage. And when the phase and the occlusion is not very good or bad, I prefer orthodontic surgery. For this reason, this is the typical patient with class 3, treated the patient with rapid maxillary expansion and facial mask. Now, 3 years later, it's time to put brackets in the upper and the lower, even to finishing the patient with a class 2 elastics. And the end of the treatment with a very good occlusion, a nice occlusion, and very good relationship between the maxillary and the mandible. Okay, when the patient presents a problem at the level of the face, depends of the quality of the life of the patient, the quality of the life of the patient, okay? And when the patient needs orthodontic surgery, I recommend to the patient orthodontic surgery. In general, I hate to camouflage the malocclusion when the malocclusion produces a very anesthetic face. For example, this girl. The main problem of this girl is not the occlusion. The main problem of this girl is the face. For this reason, we recommend in this patient surgery to produce a mandibular setback and at the same time to produce an mentoplastia, to produce the mentoplastia and the mandibular setback, and you can see the effect, the spectacular effect, the profile of the patient of our treatment. Another patient with an open bite, is possible to treat this open bite with screws without surgery? Yes, it's possible. But the problem is the face of the patient, is not the occlusion. The face of the patient, when you treat this patient with orthodontic surgery, is completely different when the face of the patient before the surgery. You can see the change of face patient with the surgery was something spectacular. Another patient with a class 3, is possible to treat this patient with extraction of the lower premolars. Maybe we decide with the nemotech, to analyze this, the end of the occlusion of the patient, and the most important is the face of the patient. For this reason, the class 3 is the same if you are in the Roth technique, it's the same if you are in the Damon technique, it's the same if you are in the MBT technique, it's the same if you are in a classical tweed technique, it's the same if you are in the bioprogressive technique. It's very, very, very simple. What is the big problem in orthodontic? The big problem in orthodontic is the mandibular class 2. And we have a lot of treatment mistakes. Why? Because the different schools of orthodontic, don't use functional appliance. And this is a huge problem because without functional appliance, it's not impossible, but this is very, very, very difficult, very, very difficult to treat the mandibular class 2 with success, okay? Remember that in the classical evolution of the orthodontic, are we adapting the appliance to the malocclusion or the malocclusion treatment to our appliance? In my opinion, the worst problem in the history of orthodontic is the different techniques adapting the appliances, the headgear, to the malocclusion. For example, headgear is I like very much the headgear, okay? But headgear was very popular. All the class 2 treatment is with the headgear. All the class 2 is a maxillary problem. But even, for example, MBT, excellent orthodontics, Dr. Trebisi, Professor Trebisi, recommend to use functional appliance, for example, the twin block. What is the problem? I don't know what is the situation in Jordan, but in Spain, in Latin America, in the past was very popular to use functional appliance very early, maybe between the 8 and 10 years old, and finishing the treatment with fixed appliance about 12, 13 years old, and the complete treatment is 4 or 5 years. And this is a huge, huge problem. For this reason, What is the problem? The main problem is this. If you use functional appliance to stimulate the growth of the mandible, the theoretical stimulate the growth of the mandible, okay, if you put the appliance very early, okay, very early, this is a huge problem. And this is because this is the puberal growth spurt of the mandible. The puberal growth spurt of the mandible is very late. And we are talking in boys about 13, 14, and even 15 years old. And in girls, about 12. For this reason, it's not a very good idea to put very early functional appliance to move forward the man. The second problem is this. This is a very popular treatment in my office. This is a dental class 2, and very popular in my office to put brackets in the upper, to put brackets in the lower. And now when we are using thick stainless steel wires, we are using the class 2 elastics. And with the class 2 elastic, get a very nice class 1, good correction of the deep bite. Okay, nice. What is the big problem? The big problem is that 90% almost of the clinics in the world use the class 2 elastics only to correct the mandibular class 2. Because in the mandibular class 2, it's possible to correct, to need to distalize the upper molar. But the most important in the class 2 is to move forward the mandible, not the teeth, the mandible to move forward the mandible. Okay, I would like to show, to explain our idea about class 2 with this case. This is a patient with a class 2 division 1. The main problem of the patient is the retrusion of the mandible. Present is functional shift of the mandible to the left, a cross bite here. Okay, okay. Okay. And I treated by my hands, I treated this patient. Start with a conventional treatment with stainless steel 90 by 25, 21 by 25, and put elastic class 2 with curve of SP in the upper, more class 2 elastic with stripping, more stripping, more class 2, more stripping and control of the friction. We are using this type of bracket. This is the scenery bracket from Rocky Mountain Orthodontic Company. And the big advantages of the synergy bracket is the possibility to control the friction and the orthodontic tooth movement tooth by tooth. For example, in this case, we need the maximum control of the canine, the upper right canine, and I ligate the scenery bracket in a figure of 8, in a figure of 8. This is a conventional, and if you need in the scenery low friction, ligate the scenery only in the central wings. Okay, you can see the result, a very fast treatment, very nice result, very nice smile. The patient, the parents is very happy, but please check the complete disaster of the profile. Was a complete disaster. Okay, this is a complete disaster of the profile. What was the problem? The problem was the attempt of the correction of skeletal class 2, only moving teeth. And this is a typical problem. intrusion of the upper incisor with the stainless steel curve of SP, protrusion of the lower incisor. If you produce protrusion of the lower incisor, and remember in many techniques like the miraculous brackets, passive self-ligating miraculous brackets, do you understand what is the technique we are using? You can see in a lot of patients, the lower incisor at the end of the treatment present a very protrusion of the lower incisor. Why? Because in this technique, use a very bad control of the friction. It's a very nice technique to align the teeth, only for align the teeth. But in the most difficult phase of the treatment is finishing the treatment with the control of the torque. And for the reason, at the end of the treatment, you put a class 2 elastics and produce protrusion of the incisor. Please remember this disaster. And what was the problem? According with Samir Bisara, when the mandibular growth is tending to grow the mandible anteriorly, the occlusion produced is providing a force system to perpetuate the class 2. Why? Because the mandible push the maxillary forward, and the mandibular forward, the maxillary forward, excuse me, the maxillary push in a reverse effect in the class 2 elastics and produce a posterior rotation of the mandible. This is a complete disaster when the patient is a dolichocephalo patient. For the reason, Houston, we have a problem because most of the cases, for the reason, the Roth guys and the Roth orthodontists say mandibular class 2 need orthodontic surgery. According with Profit, it's not possible to use functional appliance because the functional appliance only produce dento-alveolar effect. Okay. Mandibular class 2, we have a problem. What is the first step? I don't have a lot of time to explain this because we need for the mandibular a complete change of mentality. The first step is not true. The classification of maxillary class 2, mandibular class 2, mixed class 2 is not true. The maxillary class 2 always is a dento-alveolar problem. The mandibular class 2 always is a basal bone problem, okay? And it's completely different. We need a new classification. Why? Because the dental classification is very simple. Class 2 molar, canine, overjet, overbite, interincisal angle. But the facial class 2 is very difficult because it's a subjective, is in relationship with fashion. I don't like the classification, the academic classification, maxillary mandible mix, and I don't like, okay? I prefer to use maxillary dento-alveolar problem, and we need to treat the anterior guy and the dento-alveolar rotation and distalization of the first molars. The next is the mandible and the vertical, okay? There is completely different mandibular and sagittal class 2 problem than the vertical class 2 problem. I like very much this classification. This classification is in relationship with the syndrome. What is a syndrome? It's a set of medical signs and symptoms are correlated with each other and often with a particular disease of the cell. For the reason it's possible to have, one moment, a light class 2 or a severe class 2. What is a light class 2? It's a class 2 only with a molar problem. Next, molar problem and anterior guide problem. Next, maxillary problem. Next, muscular problem. Next, mandibular and body ramus problems. Next, chin problem. Chin problem is a huge problem. Why? Because chin is 100 genetic, 100 genetic. If the patient presents a retrognatic chin and is the morphology of the chin, the patient needs orthodontic surgery, even if the patient is 6 years old. TMG problems and or craniofacial or syndrome problems. For this reason, the molar class 2, very important, adjust the molar to know very well the role of the first molar in the patient, to know the Andrews keys, to know the ideal occlusion of according with Andrews, the rotation, very important, the rotation of the first molars, the cephalometric analysis of the patient. For example, in the maxillary problems, I recommend always to start treatment with maxillary expansion. Why? Because we need unlock of the malocclusion. We need unlock of we need to unlock the mandible and to move forward the mandible. And for this reason, the first step is to put quachelis or to something to produce expansion. And next, the use of a utility arch to control the anterior guide. Okay, I like very much very simple treatment. Headgear is not a very popular treatment in our office because the patient and the parents hate the headgear. But headgear is very, very good treatment in the maxillary class 2 treatment. Why? Because it's very cheap. It's very cheap, produce an expansion effect, produce a distalization effect, produce this rotation effect, produce an increase of the vertical effect, and this produces a lot of advantages. For this reason, I like very much. It's very important to finish in very well the cases and to engage the first molar. Okay, this is I don't use the headgear, but I think it's very important to analyze the use of the headgear, even in patients, because it's very cheap and the effect is very spectacular. Don't use very sophisticated and very expensive appliance, because you can see this case. It's a class 2, divide, collapse of the maxillary, and use only a headgear. Only, this is a headgear. Only with the headgear and with very simple appliance is enough to treat this patient. Okay, another patient. The main problem of this patient is this. The main problem of this patient is the class 2. First step, distalize the first molar. Second step, to close the space, the premolar and canine. What is the problem of this type of patients? We need a sliding mechanism. To a sliding mechanism, the best bracket is a passive self-ligating bracket. And the worst bracket is the conventional bracket. For this reason, I like very much the scenery, because with the scenery, if you need in the upper incisor the control of the torque, it's possible to ligate in this way. But if you need in this moment to move backward the canine, the premolars, ligate only in the center. You ligate only in the center the canine and the premolars, and the friction is close to zero. It's close to zero. Another patient, very simple treatment, maxillary dental class 2, very simple. Okay, what is the problem of this patient? The shift of the upper midline to the left. For the reason, what is the problem of the shift of the upper midline? Very simple. The problem is this. What is the treatment? The treatment is to put brackets in all white into the mouth, to put brackets very fast, a coil spring, not. The first step is to put the first upper molar in the correct position. In this case, we are using the upper pendulum appliance to distalize these molars. The end of the treatment, and you can see the ideal correct position of the second upper premolar, of the second. More cases, class 2, division 1, dental class 2, not mandibular problem, dental problem. The ideal treatment for the dental problem of the class 2 is the class 2 intermaxillary elastics. In the technique, we combine in the anterior incisor ligate in the figure of 8 to cross, to increase the torque, to control the torque during the retraction of the upper incisors, and the canines and premolars ligate in the center to get a very good sliding of the wire and move the wire to the back. Okay, very important in this patient with dental class 2. Please check the rotation of the molar, check the position of the second premolars, and check the uprightening, uprightening of the lower premolars and the upper premolars. The same here. A patient with a rotation of the upper molar, okay, we need to distalize the premolar. Okay, using a pendulum appliance. We use a pendulum appliance to the first step is to correct the first upper molar. Now we are using intermaxillary elastic to engage the occlusion. Okay, very simple, very important. Now, to move canine and premolars to backward, we are using the finishing the treatment. And the most important is this. You can see before the treatment, the upper midline shift to the right with the crowding, with a narrow maxillary. And now you can see the face at the end of the treatment with a very nice smile, with a very broad arch. Next, the same, quite simple. Simple, because in this patient, what is the problem? The problem is this. The problem is the canine, but we need to move backward the molar. The first step is a palatal bar to the control of the first upper molars. Next step, remove this more temporary molar, put a coil spring, a night-tie coil spring to distalize the premolar to produce a forward movement of the lateral incisor and to correct the crossbite of this tooth. Now it's time to put class 2 elastic because the patient presents a dental problem. Okay, shift to the class 2 elastics and finishing the treatment. The same, the big advantages is this. The shift to the upper midline to the right. Now we have a very nice upper midline without extractions and with a very nice control of the premolars and the canine. Another patient with a crossbite, okay? The crossbite in the right. And we need now to the crossbite, we put the elastic in the upper and in the lower. we use the coachelis to expand this molar and to control the expansion with this type of bypass arch wire and the end of the treatment. And you can see the nice smile of the patient, okay, because the patient presents a class 2, dental class 2. Even in patients with with a collapse of the maxillary, with a problem in the maxillary, we are using rapid maxillary expansion and a very good control after the rapid maxillary expansion, a very good control, a very good negative control of the molars and the premolars. Okay, remember this, the occlusion of the patient, and remember the Andrews keys, the incisal angle, the inclination of the second order burns, the Monson and Wilson curve. And I like very much, for example, for the diagnosis of the class 2, this diagram. This is a patient, okay, and this is the distance between the first molar and the pterygoidea vertical line. This distance is the age of the patient more 3 millimeters. And this is the distance between the molar and the lateral incisor. It's about 25 millimeters. When the patient presents a rotation and mesialization of the first molar, okay, increase the age and 3 millimeters, increase this distance and decrease this distance. What is the plan of treatment? The first step is to put the molar backward to control the molar. For this reason, I like very much this diagram. For example, in the number 1, the patient presents class 2 in the right and class 1 in the left, okay? And this is the, according with this, only the problem is in the right, not in the left. Only the problem is in the class K9, class 2 in the right, not in the left. Overjet is normal, IMB is normal. The distance between the molar and the vertical line is increased, only in the right side. For this reason, what is the treatment? Very, very simple. The treatment is only the treatment of one molar. You need to correct the first upper molar, correct first the molar, second the premolar, and third the canine. But in the third case, class 2 in the right and in the left, class 2 in the canine are right and left, but the distance between the molar and the lateral incisor, the distance is completely normal. And the distance between the molar and the pterygoidal line is also normal. For this reason, what is the problem of this patient with overjet increase? Class 2 in the right and in the left canines. The plan of treatment of this patient is to move forward the mandible. Okay, to move forward the mandible. For example, in patient like this, with a protrusion of the maxillary, what is the treatment? The treatment is the use of the C modeler for Cervera to correct the protrusion of the incisor, to correct the overjet, to control the growth of the mandible. And now it's time, to finish the case. Remember this, the hypothesis, the Melvin-Moss hypothesis, the proprioception occlusal hypothesis for Petrovic, the connection between the mesencephalic nucleus and the change of the dynamic of the mandible, the relationship with the functional appliance and the appliance that is possible with this appliance to stimulate the growth of the mandible, okay? And you can see here, in many cases, it's possible to change the face of the patient with a rapid maxillary expansion. I like to use the rapid maxillary expansion in these patients, okay, to change the upper airways. Like in this patient with a maxillary collapse, we are using the rapid maxillary expansion and expansion very fast the maxillary. And in my office, it's very important the diagnosis of the patient. Remember also this. Remember the tongue, the role of the muscle, okay, of the patient. Remember this, that this is very, very important, and to understand how to work the functional appliances, okay? How to work the functional appliances. For this reason, what is the philosophy of the treatment? The genetic...
Sorry,
yes.
we have 5 minutes.
Okay. Do you know something?
Sorry?
Yes.
5 minutes we have.
Okay. One moment. One moment. And what is the for example, the treatment in our office, what is the, one moment, the classical treatment is this. One moment. Well, okay. Okay, the idea is very simple, is this. We treat with a functional appliance, stimulate the growth of the mandible, but at the same time, stimulate the alveolar bone, apical, okay, to the teeth. Okay, this is the idea, to stimulate the alveolar bone here and here, and to stimulate the growth of the mandible. But remember that is not true. It's not possible to stimulate the growth of the mandible, of the basal bone of the mandible, or only to stimulate the mandibular with the condyle. For this reason, in a patient, the treatment is to correct of the molar. Second, to correct the bite. Third is to put functional appliance. Okay, and this is the, for example, a patient. We use the first step is to align the teeth, to increase the overjet, to create the space to move forward the mandible. After we use the twin block, and we use the twin block, the digital or conventional twin block, at the same time that the brackets and the wires. Now is a new periodontal proprioception, stimulate the new periodontal proprioception, and now the patient present the jumping the bite. This is a concept from angle. Jumping the bite. The patient jumping the bite now is not in a true class 1. It's like a false class 1. But in this moment is the moment that we are using a lot of class 2 elastic, short and heavy. And with the use of this class 2 short and heavy elastic, finishing the treatment. And this is the retention, because we finish the treatment very early. We use like a retention, a functional appliance to avoid the relapse. This is the patient years later, and the patient years later, and more years later. Another patient, the bite, collapse of the mandible, retrusion of the mandible. If you analyze the nasolabial angle, is a mandibular class 2. Okay, this is our analysis or forecast for the treatment. The objective of this patient is, the first step is to produce a protrusion of the upper incisors. because we need to move forward the mandible to avoid the disaster of the patient that we show it at the start of the lecture. Okay, the idea is this. Okay, now we have to analyze the cephalometric analysis, maxillary expansion, control of the incisor guide, mandibular unlock, first jumping bite, second, the use of functional appliance, second, jumping bite, and finishing with the technique of alignment, leveling, closing space, and finishing with the straight wire, low friction with the synergy bracket. We use for the maxillary expansion equihelix, for the incisal guide bypass arch wires, for the functional appliances, Frenkel, Bimler, or another type of Frenkel. We use the combination between the twin block, the bio-nature with first equihelix, second the bio-nature with brackets and wires. And you can see here, finishing the treatment very fast, okay? And you can see the face of the patient. It's completely different, this type of patient. We produced, the first step was the protrusion of the upper incisor. The second point was the use of functional appliance to stimulate the growth of the dental-alveolar growth of the mandibular bone apical to the teeth. This is the patient, and you can see the patient 3 years after the treatment with a very stable occlusion, with a very nice occlusion, with a very good engaged and very good dynamic occlusion. This is not a 100% of stability, okay? Because in many cases it's not possible to stimulate the growth of the alveolar bone or the mandible, but in our hands, the best result to treat patient with mandibular class 2 is the combination between the use of functional appliance and the fixed appliance. The ideal in the future is the digital functional appliance. This is the ideal for the future, okay? Okay, I have more cases, but I prefer if you want questions, okay?
Okay, we have like one question, and I'm going to ask you the first question if you don't mind. Now, regarding the clear aligners, which age do you prefer to start in for children? And does this kind of manufacture, do you manufacture it in Europe?
No, I don't manufacture. This is manufactured in a company in Spain, in Malaga, in the city of Malaga. The name is Alinea Dent. I don't have experience to manufacture the aligners at home, okay? Because the main problem with the aligners at home is the price of the resin, okay? It's not very easy to organize the aligners at home. Maybe in the future, with the depend of the price of the printing. The idea is, if you are using, for example, Invisalign, you have Invisalign kits. The idea of Invisalign kits is to put all the treatment of the patient using only aligners. My idea is different. The idea is to put in the first phase of the treatment something very simple, 4 brackets, 1 coahelix, 1 lingual arch, and using only the aligners in the last phase or in the last part of the mixed dentition. Immediately before the loss of the exfoliation of the second temporary molars, and before the eruption of the upper canine.
Okay, let's go for the second question. It's Dr. Riyad. Let's unmute.
Yes, I will do it. Just a minute. دكتور رياض تفضل لو سمحت.
Thank you for your lectures.
Okay, thank you.
First part is that your lecture, the title of it is to use a liner in children's, in mixed dentition, right?
Only, yes.
Yes. So we have a problem with the adults, with the cooperation to use a liner.
Yeah.
When you give a liner to children's, usually you have a problem that they will not wear it. So instead of this, we can use, as you said, any type of fixed appliances and get the result. So there's no need to use a liner in mixed dentition, and because the cooperation of the children is very difficult.
Yes. The question is very simple. If you put aligners in children, the first you put aligners with the idea to put all the treatment with the aligner. The big problem is this is very unstable, the aligner, and the kids remove the aligner. But we are talking about to put the aligner only during a very short period, maybe 6 months, 1 year, even less, because it's between the loss of the second temporary molars and the eruption of the upper canines. It's a very short period. In this short period, it's possible to get a very good retention of the aligner. Even in my experience with the aligner in kids only in this period is very good.
I think that we can finish the case with fixed appliances, and that's it. There's no need for aligners with the kids. The kids, they are uncooperative to use a liner. We have this problem. The second part of your lecture, you cover everything. You cover class 2, class 3, functional appliances, headgears. Nowadays, 90% of orthodontics, they don't use headgears. They use the implants, distalization.
Yes.
Functional appliances with you. I'm also with you to use a face mask in young children's rapid maxillary expansion. But in the same times, you cover everything. This is, I don't think that what you are dealing with is that what type do we have at this lecture? Is it lectures for early treatment or is it lectures for everything? I am sorry to say that.
No, the question is very simple. The question is, the first step is I use a lot of mini screws. In fact, I have mini screws, and I use a lot of mini screws. The lecture is 2 parts. The first part is about the mixed dentition, and the second part is the class 2 treatment in the class 2 treatment. In my office, we treat the patient of class 2 with functional appliance and fixed appliance at the same time. Another question is the cooperation. Okay, in my office, I use a lot of functional appliance, and I don't have problems with the functional appliance. A lot of people talk about, I have a lot of problems with the kids because the kids don't use the appliances. It's not possible to put removable appliances in the kids, or it's not in my office. I have a good, because the main problem in orthodontic today is how to move the mandible forward without functional appliances. Not because Forthus or another type of appliances like Forthus, they produce a dento-alveolar protrusion of the lower incisor. This is the question.
دكتور شادي تفضل. دكتور شادي بده يسأل سؤال. Dr. Shadi has a question.
Yes. Thank you, Dr. Majd, and thank you, Dr. David, for the informative presentation, as always. Actually, there was a question in the Q&A tab, but I think it was similar to Dr. Riyad's question, so we'll consider this answered. But I do have a question of my own, if you don't mind, and it's also regarding the treatment of kids in the mixed dentition with the aligners. So you mentioned that you actually reproduce the shape or the size of the unerupted teeth during the mixed dentition as you're treating with aligners. So can you just give us a brief, quick note about how you actually predict accurately the actual size, and do you actually have to take rescans or new impressions?
Well, the question is very simple. The question is, there is two possibilities. The first possibility is more sophisticated, and you can see here with the and the first question is if the ideal is to use a CBCT. Okay, you take the shape of the teeth. Another very simple is to take the opposite tooth, or to use a tooth very similar in the shape in a bank of tooth, and to put in a bank of tooth, and to more or less to put in the space for this tooth. Okay, it's possible. The ideal is with the CBCT, but it's not necessary. It's possible to put with a bank. For example, imagine that you have the eruption of the first premolar in the upper. It's possible to use the first premolar to create the shape of the canine.
Yes.
Okay, but is this really accurate towards the later stages of the treatment when you want to fine-tune the position of the tooth?
More or less, because you need more space. If the canine, the measurement of the canine is 8 millimeters, you need to put more or less 10 or more. Okay.
Okay, thank you. Thank you very much.
Okay, thank you very much, Dr. David Suarez, for your beautiful lecture tonight.
Thank you.
It was our real pleasure having you twice this month. Hopefully we will meet you soon. Okay, have a nice evening. And my dear colleagues, thank you very much for attending tonight. Happy Ramadan. كل عام وانتم بخير. رمضان كريم. إن شاء الله نلقاكم في القريب العاجل. كل سنة وانتم سالمين. Dr. David,
thank you very much, and happy Ramadan. Okay.
Thank you so much. Thank you.
Thank you very much.
Goodbye. We'll be ending the meeting now. Thank you very much.
Thank you. Thank you very much.
Thank you.